Good morning, everybody. I'm Zahid Juna. I'm an interventional cardiologist with UNC High Point Regional Hospital. They asked me to come by and give you a talk about post-cardiac arrest management, and that's a pretty broad topic, but specifically looking in the pre-hospital setting. I think this is a lot of stuff that you guys do every day. It's second nature to you, but it's just a refresher, a reminder of kind of what you do and the importance of what you do in the cardiac arrest patient, because a lot of things happen between when you assess the patient, treat the patient, and then get the patient to the hospital. It's a key part of their care, which is very crucial to their outcome and their survival. And this is very informal. You stop, ask questions, and say, hey, no, we do things a little bit different, because everybody has a little bit different algorithms. Each department, each county kind of has set up their own kind of guidelines and rules and kind of what they follow, and this is just an open discussion, but at least it's food for thought and how we treat patients in cardiac arrest. So feel free to say, hey, Juna, we do things a little bit differently. This is how we do it. This is why we do it. Stop. It's, again, very informal. So what is cardiac arrest? Here's the ACCHA definition. It's lengthy. There's a difference here. Some people will say sudden cardiac death versus cardiac arrest. They're two different things. Death means death. Cardiac arrest is where you have no normal breathing, no signs of circulations, and if corrective measures are not taken, it will progress to death. So the terms you don't really want to use interchangeably. But you'll see in literature, you'll see in presentations, a sudden cardiac death, and they're describing someone just cardiac arrest. But you shouldn't use it if the event. You shouldn't use sudden cardiac death if it's not a fatal event. All right. So a lot of people experience out-of-hospital cardiac arrest every year. It's about 15 to 20% of all mortality is caused by cardiac arrest. Obviously, there's an underlying etiology. And 8 to 10% of these treated out-of-hospital cardiac arrest recover to resume normal lives. A very small percentage. So the odds are stacked against you. Usually in cardiac arrest, whatever the cause is, and that's important, is to try to determine what the cause is. It leads down to three different kind of rhythm pathways. One is VTAC, the other is VFib, and the other asystole or PEA kind of falls into one category. And that's the big thing, kind of what you determine when you see there and you get to the field and you decide how to treat these patients. And I'm not going to talk about ACLS and be like, you guys are experts and pros at that. You know how to assess this patient gets on the scene. You do your thing. Good compressions, again, that sort of is the best. It's the best for outcomes. So usually, this is just showing people don't do well when you have cardiac arrest. They found 72% of the people in the field died who survived a hospital admission. So that's, and then even in the hospital, say they're in the hospital, right? They have cardiac arrest, they still a very poor outcome, 62%. If they've been trying to resuscitate them after 20 minutes and you get return of spontaneous circulation. So what should be the goals of care? When you get the patient, you do your thing, you get circulation back. We want to first try, in that first, every minutes, it may feel like it's hours by the time you get them from initial assessment to the hospital, but it's really pretty quick. You guys do a great job, you get them there, but there's a lot you need to do, or a lot of things that can be done in those 5, 10, 15, 20 minutes. And the first thing you want to do is try to determine and treat the cause of cardiac arrest, right? If there's something there that you see that you can do, are they bleeding? Are they hemorrhaging? Is it because they had a heart attack and they had chest pain? Or was grandma real sick and had a bad cough and then developed bad pneumonia and is septic? I mean, there are all different ways that you're going to kind of approach this, and how you're going to do it initially is how you initially treat them could make a difference in how they do. The other thing you want to do is minimize brain injury. You want to manage any cardiovascular dysfunction, their blood pressure, their rhythm, and then managing other problems that may arise from global ischemia or reperfusion injury. And that's sort of what, when you get into the hospital, what we do. So as you can see, the most common reason for cardiac arrest most times is going to be acute coronary syndrome. The other one you want to do is an arrhythmia, electrolytes. Patient's been having diarrhea for 2 weeks straight. Their potassium, their magnesium very low. It puts them at risk for having an arrhythmia, fluid around the heart. But then that's the heart, those things. Then you got the lungs. You got the people with pneumonia, pulmonary embolism, tension pneumothorax. But you guys actually put needles out in the field if you suspect tension pneumothorax. You'll do that, right? So you know those signs where you see the trachea deviated, you don't hear breath sounds, they're hypotensive. You put the needle in. That's a correctable cause of cardiac arrest. Obviously, trauma, bleeding, GI bleeding, drugs. That's a big one right now. Prince died, probably too much opioids. A lot of that. So the thing is, if you can, whatever information you can glean from the scene, it's going to help you determine how you decide what you're going to do in treating those patients in those few minutes to 20 minutes between them getting to the hospital. And then obviously these are the different conditions that you can, that are treatable. There's a lot of them. We just kind of touched through that. But again, the biggest one you're going to see is myocardial infarction. I mean, that's the most common one, and that's the one that you can do corrective measures that really can make a difference. So our initial assessment, like you get to the scene, you do your thing, but who can provide any information? If they tell you a 64-year-old gentleman, he had chest discomfort, and he went out, you got to think, okay, is it most likely common thing to be a heart attack? If it's grandma, like I said, was coughing, has been sick all week, and she had a fever, well, you got to think sepsis, pneumonia. And then the other thing you want to do is physical examination. It's kind of your ABCs. Is the airway patent? You're looking at their circulation. What's their skin like? All those kinds of things. Those are all clues that are going to help you in determining what you're going to do for that patient after you've resuscitated them. You want to look at the neurologic scale, right? You got your pulse back, but you need to are you going to intubate them? Are they awake? They're not awake. What's their Glasgow coma scale? Do you think you're having a bleeding stroke? See any deviation in their eyes, their pupils, all those kinds of things. So those are all important things. And the last thing is a diagnostic test. So you're a little bit limited in what kind of diagnostic test you can do. But what's one thing that y'all have I imagine you have them all in your trucks right now. That's the one thing that you can do to tell what's going on. What do you guys think you have? What kind of things do you have that you can use for diagnostic tests in your truck? Glucometer, great. See what other things? What's that? Yep, perfect. What else do you have? They got an EKG. I see y'all transmitting EKGs, right? So those are real important things to do. The what's their glucose? Is it just a simple thing? Are they hypoglycemic? Is that why they're bradycardic, unresponsive? So use those tools. You got to remember to use all those tools, and you're going to be doing them. So here are the management strategies that I always look at. One, when you see these, you want to the airway is very important. You want to have airway control. After you regain spontaneous circulation, you got to control the airway. You got to optimize ventilation and oxygenation. You want to stabilize any rhythms, because as you probably know, you'll get a pulse back and all of a sudden you see VT, you see VF, you don't have blood pressure, all this stuff's going on. So you got to stabilize the rhythm, and you got to do blood pressure optimization. Then the next thing is hypothermia. What do y'all do do y'all do much of that in the field at all? Yeah, chilled. So you do chilled saline through there? Okay. Good. And then seizure control, obviously, you have someone who's seizing on you, that's brain tissue that's getting fried. So what do y'all usually do for that? Do you have any kind of protocols or things like that? And that's something you can think about. And then obviously the glycemic control. Those are all the things that you can do in those first 20 minutes that really can make a difference. So for the respiratory, you got to make sure the airway is functioning properly and stabilizes. That's the biggest thing, is you get the airway in, but there's so much going on. You're pushing on the chest, they're moving, it comes out. I've seen it. I've seen it happen. I was like, geez, we're working so hard, we're getting the arm, well, why is she not doing so well? Well, when we transported them off the truck onto the table, we probably yanked on their ET tube too much, So it happens. So you just have to be cognizant of that. And then maintain normal ventilation. That's the other thing I see a lot is people get real excited and they squeeze that bag a lot, really quick. And so you want to keep it at 10 to 12 breaths per minute. And so what's the you want to keep their oxygenation at 95%, and the end tidal CO2 is about 35 to 40%, or 35 to 40 millimeters of mercury. Do y'all have numbers on yours, or is it kind of like the color purple, yellow? And, okay, good. All right, good. All right, I'm just and then and the reason you want to avoid hyperventilation is that when you drop the PCO2, what do you think happens to the brain? Y'all know? You get yeah. And so what that does is vasoconstriction and more cell death, likely more brain. So you got to be real careful not to bag too aggressively. And actually, I think y'all do a pretty good job. When I see in the hospital, I'll see them going, especially you get the doctors in there and we're waiting for respiratory. We're just pounding away. That's a bad thing. So the other thing is to stabilize your rhythm, and don't be afraid of cardioverting people. It's not, if they're hypotensive and it's really fast and you're not sure what it is, you can shock them. Don't forget about pacing people. I see it a lot too, where they're bradycardic. If they're unstable, go ahead, pace them. Put them down and pace them. And then, a lot of times you have a patient that has VFib, and you resuscitated them with an electrical shock, you've got the rhythm, it's stable. There's really no need to, at this point, hit them with amiodarone or anything. Only if they have a recurrence of it, then you'd probably do it. It's better if if you suspect there's an electrolyte abnormality, or if there's, then you give them magnesium or potassium or things along those lines. But I think that's a little bit difficult for you. I don't know, do y'all do little iStat labs where you can tell right away, anything like that on the truck? All right, so, and then really, we use amiodarone. I would just keep it simple, stupid. Just use amiodarone. People used to use lidocaine and beryllium. You see that? I think everything is just amiodarone is the drug that you should probably stay with on this situation. All right. And so your blood pressure. It's important. We like mean arterial pressure, and so and that kind of ranges between your systolic 110 to 140. And so the first thing you want to do, depending on what's going on with the patient, is determining what you're going to use. Most of us use volume replacement, right? So what do y'all, and you want to use isotonic boluses. So that's lactated ringers or normal saline. You don't want to do hypotonic solutions, 1/2 normal saline, just D50 in water. You want to avoid that, because what that does is increases cerebral edema. And so, and don't be afraid to start vasopressor agents, right? What do y'all carry on your trucks? You got it all? Epi? Yeah, that's a good one. It's easy. You can mix it. You got the, just put 2 milligrams in a 500 cc bag of saline, and you got 4 micrograms. And that's a decent dose to start at, 4 micrograms. The other ones you can use are norepinephrine or dopamine. All those medicines are pathways that lead into epinephrine. So just if that's what you need to do, use it. And you got to be careful, because if you're a patient who's got, they're bleeding, they're hemorrhaging, you want to give volume. But if you've got a cardiogenic shock patient who's had a big MI and you see froth coming out of their ETT, you don't necessarily want to give them. You want to give them a pressing agent to keep their blood pressure up. So you have to know the scene or the scenario. So, do you guys have any questions or anything? What do y'all say? And it's okay to use it. Just use it. Don't. And so why do we want to use pressors? Most patients are catecholamine dependent. They've sometimes got an epi, and you initially get that, you ever say people are like, okay, we're in the clear, we're going to cruise on in real quick, and they're like, well, what's going on here? Blood pressure's dropping, and that's not uncommon. You're going to get that because you've got myocardial stunning, you've got LV dysfunction, and you'll see it right here. You've done your CPR, you've done it, you've shocked them, you've got good pressures, and you think you're good. You just got to get them on into the hospital. But that's more times out of not, you're going to see this crump right here. And this is, these people particularly in this study used dopamine, and they got it back. So keep a low threshold to start mixing that bag of pressors if you need it. It's cheap. It's you just Um, and we'll figure that part out later if we need to keep it going or not. But the big thing is you just want to keep that perfusion pressure because you need that circulation to the brain because you want to minimize the injury there. So you've got them through all of this. You've got a stable rhythm. And I think this is the part where you want to think about hypothermia, right? A lot of us don't think about it. We got too much going on. But, if it's not related to trauma, so they don't have a big old piece of metal sticking out of their chest or their gunshot wound or something like that, or it's not major hemorrhage or bleeding, or you don't think it's infection. That's the tricky one. Is it infection? Is it non-infection? And then what kind of rhythms do you use it for? And we'll talk about that too. Age greater than 16, yeah, it used to be 18, 16, you just don't, it's not, just in the little infant, it's a little tricky. So if they're a decent sized human being, it's probably okay to do it. They used to say if you're pregnant you shouldn't do it, but I think that's changed too. So you can probably do that. The patient's got to be intubated and unresponsive. If they're talking to you or they're kind of moving around and they got purposeful movement, don't do it. Don't give them the cold saline. Don't give them that's just mean. And their initial temperature, if they're already pretty cold for whatever reason, it's not going to help because our goal temperature is between 32 to 34. Some studies will say even 36 is good enough, just depending on what you're dealing with. So this is just saying it, it's okay. They all say it's good. We should try to do it. And so here's your algorithm. Is what I look at. Do y'all keep a particular algorithm? If you get return of spontaneous circulation, you get the ET tube in place, you got a good temperature, you confirm it's not responsive to vertical stimuli. You get your 12 lead EKG because when you get cold, you can change your EKG a little bit. So I think you should put ice packs and groins and stuff in the axilla. Even get it around the back of the head too. Get the head cold. So the cold saline is the controversial part, right? Do y'all do the cold saline? So in animal studies, it shows to be very effective, in decreasing hypoxia, decreasing the hypoxic injury to the brain and cell death. They did it they looked at it in pre-hospital settings where it showed that it didn't really have an outcome in mortality, but what it did cause was something called cold diuresis, which is increased use of, where you have increased loss of fluid, become a little bit more hypovolemic, their magnesium, potassium, and things like that drop. I think if it were me, I'd say just give me the cold fluid. Just get me cold because that makes a difference. So that's a little bit debatable of what to do, what not to do, but you're never going to get more than 2 liters, right? And 30 mLs per kg is probably good. And then you can give some medicines. If they start shivering, you can give diazepam or Versed or something like that. You keep that all in the truck. Diazepam, Versed, you got all that, so that's good. It's just, and don't be afraid to use it. Just go ahead and give it. And then the timing of hypothermia is you want to start as soon as possible. We usually keep it for 48 hours, and our goal temperature when we get them is about 32 to 34 degrees centigrade. We want to do for 12 to 24 hours. We want to keep them cold before we think about going rewarm. And that's just, probably wonder, well, how long do we do it for? Why do we do it? And so hypothermia is not totally a benign thing, so that's why you got to be real careful on who you select to use it, right? Adverse effects would be mild. You can bleed, right? So if you see a patient who's had a cardiac arrest, like we had one the other day, PEA, young lady, PEA, in fact, you probably brought her in, PEA, worked on her for a long time, and then we kind of looked at her exam and we thought maybe one of her pupils was a little bit asymmetric, and so the decision was, well, do we cool this patient, do we not cool this patient? But you know what, she had a big head bleed, right? So you don't want to do that. So you got to pay a little bit of attention before you start pounding in the fluids. So my first thing is, if you're unsure, then stick with the ice packs before you give the cold saline, because you're going to get some drop in pressure, but you're not going to, temperature, but you're not going to, you're not going to get down as quick as you would with the cold saline. You do get increased risk of infection because what happens is your white blood cells, which help fight infection, become very sluggish, and that's why we don't want to do it. That's why we kind of avoid doing it in people who we think have infections. The other thing is if they're really bradycardic, it slows down conduction, your heart conduction. So you got to be a little bit be careful. And it's not really been shown to benefit people and patients with non-shockable rhythms. So like you got the PEA arrest. Long term, we don't really see much benefit. We really focus in on VFib, VT. But the guidelines would tell you to just do it on everybody, and then we'll sort it out later. So to keep it simple, Stu, just to do it on everybody, but just keep in the back of your mind, if you have like choices you have to do and what you can do in your timing, and it's like PEA, then maybe this is not as beneficial. So glucose management, real important. Hypoglycemia or hyperglycemia, you want to keep them around 120, 180. They're really low. Just give them some D50. If they're super, super high, you might need to give them some insulin. I don't know if y'all do that on the cart now. Just fluids. All right. Well, so, but that's the big thing, because hyperglycemia, bad for the brain too. Hypoglycemia, really bad for the brain too. So, and then seizure management. If they're seizing, you think they're seizing, you gotta try to quiescent that. Give them some diazepam, push it. The blood pressure's okay. Just you gotta manage that. So those kind of things are the things that will sort of really kind of help the patient most. So your diagnostic test, somewhere in there, you got to get the EKG done. I'm not sure where you do it, but again, a lot of this is going on simultaneously. There's two of you. So if you see it, again, the most common reason for cardiac arrest, so you got to screen for STEMI or ischemia. You guys do a good job. Just send that on over. Send it right on. Call it if you want to, and we'll sort it out. And then, because the quicker we get them there, the quicker we get to the lab, better things happen for the patient. So, and also, you're out in the field, you got a cardiac arrest patient, you got small little hospital that doesn't really have anything versus hospital that has stuff. Probably take them to the one that can do cath, that has a comprehensive post-cardiac arrest and critical care capacity, right? I think that's all standard protocol, but there's sometimes sometimes you can't. But is it better to keep resuscitating, doing good CPR, and getting the patient to some place where they can do something versus kind of stopping? Going to a smaller hospital, trying to figure it out. Again, very debatable, but we would always say get them to the center where they can get the most done if it's reasonably close. If you got to go 2 hours versus, then you got to. I don't think Davidson County's that big, is it? Before you get to. What other hospitals do you have in the county? Which hospitals are your?
Two. We've got Lexington Hospital in
county, and then what other ones do you serve?
is going to be High Point, Baptist, Forsyth, Rowan, and Northeast, and part of Southern County.
Okay. All right. So you just depend on where in the county where you decide to get to. So.
It can be up to an hour.
Oh, is it? Yeah, just depending on where you go. Yeah. Well, yeah, but sometimes, it gives us 30 minutes to get what we need to do, so. But, all right, you guys want to go through a quick case or something? And see what y'all do? All right. You're at the local high school football game. Wow, I misspelled that pretty good. All right, okay, 50-year-old guy collapsed on the field at a Friday evening game. You get there. Coach greets you. He said he was having pain. You see a group of people all just standing around. Fortunately, there's a firefighter there who was just watching the game. He starts CPR. That's your rhythm. What do y'all do? What are you going to do there? All right, speak up. Just go ahead. What is that rhythm?
Immediate good, uninterrupted CPR.
Yep. Start CPR. So you've done your CPR. You got your rhythm. What kind of rhythm is that? Is that a shockable rhythm?
Yeah.
Yeah, right. So we're going to shock that, right? All right. Boom. You shock him. Quick reassessment. You looked him up and down. He's a little cold, but this is his vital signs, right?
It don't never work out like that.
No, I know. All right. One shock, we're okay. All right. But let's say you've done some CPR. You've resuscitated him. Maybe you did a couple rounds. Maybe this. You finally get him. You're getting ready to put him on the gurney, get him on the stretcher, get him into the car. This is your vital signs, right? So he's probably intubated, right? He's unresponsive. GC probably brought the tube down, right? Okay. So what do you guys want? What info do you want now? What What do you want to know about him?
History.
Yeah, he's telling you. Yeah, he was just standing there watching the game. He's a smoker. He's got diabetes and high blood pressure. Said he's been feeling a little under the weather a little bit, just tired, a little trouble breathing, maybe a little pressure in his chest, but thought it was just mostly reflux.
So what's the blood sugar?
Yeah, so first you check his blood sugar, right?
Oh, yeah.
It's good. It's 78.
What's the capnography?
So, good. All right. Capnography's pretty good. All right. So he's okay. His O2 sat's okay. You've got, that's fine. So you think what's your kind of your thinking? What's going on? What does he have? He had VF. You've shocked him. He's got this. What's kind of your working diagnosis? What's the thing? You think he's infected? You think he's having a cardiac event? You think what's running through your mind?
I don't have enough information.
What's that?
I don't know yet. I don't have enough information.
Okay.
I mean, if this capnography's through the roof, maybe it's a, respiratory issue that led to that, but you're not really telling me the history for that. Yeah, what's the 12 lead look like?
All right.
It's not gonna be normal sinus after a rest.
Could be. Could be.
Really?
Oh yeah.
There's that zebra?
You can have that. Absolutely. You see it. You see some hyper T waves. All right. You got that. All right. So I'm telling you, his EKG looks okay. His capnography's okay. And so he's in the truck. What you said you want a 12 lead EKG, right? Okay. So you did that. What's that? You can ice him too. You can just go ahead and start all that. Okay, that's a good plan. I would do that.
Why
That's
not?
good.
Yeah.
His glucose is okay. You go ahead and start icing him down. Put the cold packs on him. That's good. All right. Now all of a sudden you look at the monitor and he's going really fast. Your blood pressure's not registering, and you can't feel a pulse. And this is what monitor looks like. What's going on here? VTAC. So what are you gonna do? Okay. All right. Doing some CPR. Okay. What is it? Yeah. Good. Yeah. Go ahead and shock him. Oh yeah. You mean even if you see that right away, you can just go ahead and shock him too. But you can get a few rounds of CPR in there. That'd be good. You want to get the perfusion going. All right. All right. So now here we go. So what's going on here? He got his rhythm back, but you're looking at his vital signs. He's still sinus rhythm. Yeah. Yes. Yeah. So what do you think's going on here? I mean, it's kind of low. His end-tidal is low. His blood pressure's a little bit low. We could be in the crump. Yeah, we could totally be in the crump. So what are you guys thinking? You want to hang epinephrine? How many would have you given amiodarone here after this? You went VF, VT, and repeated. Would you give?
What does that go to? Is that recurrent, or did we convert that to?
So you went to VF, sinus rhythm, with a pulse, then back to this.
I've gone into a shock therapy twice now.
Yeah, I would do that. I'd hit him with amiodarone. I'd hit him with 150 of amiodarone, and that's about it. Anyone disagree? Would you think so? I mean, it's up for debate. All right. So our blood pressure's still a little bit low. Our heart rate's 85. We've shocked him. Something's low here. We're either not perfusing very well. So what? So you got a new guy in there, brand spanking new, and he's at the head of your bed. What's one thing that might give you some kind? Yeah, you gotta because what happens when you hyperventilate? Your end tidal volume goes down. You decrease venous return. Your blood pressure gets low. Okay, so the new guy, tell him he's excited. His first code, first down. He settles down. You're like, whoa. Does he? Why doesn't the new guy ever get the bag?
Because I had it.
All right. Well, this isn't Davidson County, then. We got some. All right. What's going on here now? So what have we done so far? So we've started amio. We've shocked him twice. We've checked his sugar. or glucose, it's fine. We start an epi-drip. I'm showing you an EKG that was, I didn't show you an EKG, but I said it doesn't look too bad. You're like, huh, what's going on here, right? You're pacing that. Okay. What if I tell you, you look at his exam, and you're like, his belly's rigid. It's full of air. Yeah. Or it's really firm. What is this?
Check the tube.
That's what you need to do, right? Somehow, new guy somehow did something, right?
That's why.
The new guy, no offense if you're the new guy, right? So this is probably a response to, you see your ET, and it could be anything though. The low end tidal volume could be that he's just not perfusing, his heart's stunned, his heart rate is low because it's right. So you've adjusted his you think it's ET2, right? What do you think? You think?
Possibility.
So you adjust it, all right? And you're like, okay, that's good, right? Yeah. Good. All good things. All good things. You want to make sure you get good venous return, right? Here. Oh, shouldn't have said that. Does anyone want an EKG again? Do you ever repeat the EKG?
Oh, yeah.
All right. Okay, so we're like, so you've clinically seen something change here, right? He's not getting better. So we got to, so whoa, what does that look like to you? Yeah. So what do y'all usually worry about with inferior STEMIs? Right? So the things you want to worry is hypotension, right? So you don't, yeah, right? And so the best thing to do is you get volume, right? Fluid, right? And so you start doing that. The senior person's fixed the ET tube. You're giving volume. Have we started epinephrine yet? Anyone started epi?
Yeah, that one ago.
You did that? Okay. Which one? Where did you do that? What point did you do that at?
2 slides ago.
So you did it here?
Yep.
Okay. So how much did you start? 4? Okay. And you're still here. Do you go up on it, or do you kind of wait and see, or you? Yeah.
The volume of that, I'd probably be up to 6 or 8.
Yeah. All right. So that's clearly looks like a big right coronary infarct, right? Is that what you think? Inferior infarct. All right. So you've fixed the ET tube. You've given it a little bit of this. Heart rate's back up. We know he's got a STEMI. So what have you done with that EKG? You've just transmitted it, right? And so you're gonna skip the ER, right? You're gonna go straight to the cath lab. Did they give you a T-shirt now?
Are you jealous?
I never get a T-shirt. So we're in the clear, right? We're good. Cruise on into High Point. Dr. Judas, just wake him up at 2 in the morning. He's got a big smile on his face because he's happy to be there. And he doesn't, because he doesn't get his T-shirt though. All right. So we're good, right? We've got epi hanging. We've given amiodarone. It all sound pretty reasonable. Fluids. He's cooling. Cooling him a little bit. Have we given him the IV? I don't think I've given an IV at this point. I probably would have just cooled him. And then I'd start thinking about it. We got good blood pressure, heart rate's okay. All right.
Well, but you said it's, well, never mind.
Yeah. Yeah, the belly was firm.
Now.
Yeah. You
Okay.
fixed that belly got
All right,
better.
okay.
Somehow. All right. So you're, I don't know where you are in Davidson County, but you're about 7 minutes out still. You're thinking to yourself, geez Louise, can we just get out this guy off the truck? I'm sure you guys think that too.
So that time before, it wasn't gonna be too long.
Yeah.
I got time.
Uh-oh. Now what?
Then it's taking off the cup.
What's going on now? Yeah. Yeah, we give away the pink frothy fluid in the T-tube, right? So what are we gonna do? What are we gonna do? I mean, tell me what to do. Okay, that's one thing. Why is his end tidal volume low? Is it poor perfusion?
Yeah.
Right.
Probably fluid.
So the fluid. So you're pretty comfortable with the tube, right? Belly feels good. You're hearing, right? You're hearing sounds. Okay. So what are we gonna do next? What are we gonna do next?
All right.
at his heart rate. Yeah, I'd start pacing him, right? What other things can you do to help? You got to figure out why. Why is he so bradycardic all of a sudden? What are you gonna do? What's gonna help you? You want a 12 lead? Who wants that?
Yeah.
All right, I'll give you that. Whoa.
Yeah.
What's going on there? Yeah. What's going on with the rhythm there, though? What kind of rhythm is that? Yeah, you got complete heart block, right? All right. Okay.
That's a diesel rip.
All right. So now what?
Well, the patient's gonna fix that.
What's that?
The patient's gonna take care of that.
Yeah, your patient's gonna take care of that. You're probably gonna dial back down. I would dial back down on your fluids.
Yeah.
His lungs are stiff now. All right. You can still keep cooling them. I guess that's good. I'd keep doing that. All right. There you go. You crank that pacer up to, I would even crank it up to like 100. You know, 80, right? 80. So now what?
That looks good.
Be happy.
You're happy, right? All right, you're pulling in a high point. And that's what he had. This is a real case. So that is the right point. All that one little artery. That did all that, right? See how much that you did in that period of time in post-cardiac care, post-cardiac arrest made a difference? And you get a t-shirt. That guy would have probably died if you didn't do all those little things, to remember to do all those little things. And think about it, you did about 15, at least 15 major medical maneuvers in probably less than 10 minutes. So just remember, secure that airway, stabilize that rhythm, stabilize that blood pressure. Start trying to cool people when you can. Make sure they're glucose, make sure they're, dot your I's and cross your T's every time. And, it's hard to remember everything. I know it's your job, it's still hard to remember everything. That's why you got a team. So maybe in your crew you said, okay, this is my job, this is your job, this is what we're gonna do. So, just really remember, these are the things I want you to really remember. It's your take home point here. These are the things that you gotta be thinking in the back of your mind, I gotta always be doing this, and reassessing. Because a lot of what you do in those 15 minutes makes a difference between, do they get in that 8 to 10%, or are they in the other 90% that die? Sorry, it's a lot of pressure. Questions? Anything you guys do differently? No? No? Yeah. Just gotta remember to, you gotta just keep thinking. You gotta keep asking yourself why? Why? Why is he doing this? Why is he doing this? Nice to meet you. Good luck, guys. Thanks for coming. Questions?
On the coolant.
Yeah, let's talk about that. That's fair.
Coolant's gonna cause, obviously, vasoconstriction.
Yeah.
So if you've got a blockage at, say, only 75%, so you're still getting a little bit of blood.
You mean in your heart?
Yes.
Yeah.
And then you constrict it, you close it off to, 100%. Or is that gonna?
That doesn't really affect it in the major epicardial vessels. You'll see some, but it's not gonna. Usually when you're gonna start cooling, it's usually 100% blocked artery that's causing all of this. So it's not gonna make a difference.
Even like if you have to do a cath and put a stent.
Yeah,
in,
no, we work around that. We work around that. So just, if you want to cool, start cooling. Again, the IV thing, a little bit debatable, but if that's what you do, I think I keep doing it. I mean, yeah, go ahead.
Now, with the cooling, let's say we think we're gonna get Ross. Would you say go ahead and hang it before, or only once we get Ross and we know that their GCS is
Yeah,
low enough?
I would make sure their GCS is low and you get spontaneous circulation. If you don't have spontaneous circulation, just keep doing your CPR. Don't waste time. Get a pulse back first. All right. Well, thank you very much for having me. I appreciate it.
We appreciate it.
Thank you.
Thank you.
Thank you.